And we'll be asking Tafik Desmond Sanusi to come and talk about elderly spine surgery. Is it worth it? Because we have quite a full session this morning, we are going to keep speakers to time, so 5 minutes. We will hold up a white page for 1 minute warning, and then try and keep it to 2 minutes. No?
Yeah.
Fair point. It's not his talk.
That's not his talk.
Apologies, we've had no technical issues all week, and now today they seem to be happening all over.
Apologies for that. Should be the
Right, I think we're good to go.
Good morning. Thank you for this opportunity. My name is Desmond Sanusi. I'm a STIC fellow in Birmingham. So I'm going to be presenting elderly spinal surgery as they really want it. So we all know that increasing aging population comes with significant health challenges, and spinal surgery is not an exception. All patients that are elderly that undergo spinal surgery normally goes through rigorous evaluation and also decision-making process. I would believe that recording and documentation of Fratis score could add to this. So the aim of this study is to evaluate outcomes of patients that are over the age of 80 that had spinal surgery, and also to evaluate the clinical Fratis score pre- and post-operatively, and to be able to predict possibly the outcomes of this patient, which may inform us to have a better information to be able to discover the patients and also their family. We use a Eurospine classification of spinal surgery, which divided into minor, medium, and complex spine. Majority of instrumentation actually falling under the medium spinal surgery. So we also use the clinical Fratis score, which was published many years ago and is widely used in clinical practice. So this is a retrospective study over a period of 5 years. And the inclusion criteria, patients over the age of 80 underwent spinal surgery, and also we were able to adequately document and review the information pre, peri, and post-operative information, and also be able to calculate the clinical Fratis score pre and post-operatively. So 235 patients met the inclusion criteria. I can see that the mean age is 83 years, and majority of these patients are males, and majority of them also are admitted electively. So in terms of the regional pathology, so just shy of 60% of these patients had a lumbar spine pathology, and majority of them had a degenerative spine. So most of these patients had minor spinal surgery, and the mean clinical Fratis score pre-operatively was 6. So in terms of the outcome, so we measured the outcome, the favorable and unfavorable. So the favorable ones are those patients that have been discharged from spinal follow-up, and those patients that are transferred to other facilities, or those patients that are still being followed up. And 188 patients fall into the favorable group. And what we classified as unfavorable, the outcome mortality and outpatient mortality and inpatient mortality, you can see that the 15% outpatient mortality with a lag time of 1,400 days. This is not directly related to spinal surgery that they underwent. And inpatient mortality, majority of these patients, all of them actually were admitted emergently with a 4.5%. Across the board, all of them have increased improvement in their clinical Fratis score. So in terms of the outcome, so favorable patient, like 4 out of 5 of these patients actually had a favorable outcome, as I said before, with a 50% outpatient mortality and inpatient mortality of 5%. So this is this graph, this regression analysis graph, which shows the improvement of this patient from the preoperative clinical Fratis score, actually, which is highly showed in this graph. And all these patients, as I said, across the groups improve in their clinical Fratis score. So in terms of our conclusion, we believe that most extensive cohort, this is the most extensive cohort retrospective study above the age of 80 from our literature review, and the only study that looked at the clinical frailty score as related to spinal surgery, and there's improvement in clinical frailty score at least 1 point in all the groups. We have a morbidity of at 9%, those patients that had a CSF leak or had to go back to theater. This is just the ones that went back to theater, about 2%. Neither of the patients that died, inpatient or outpatient, actually died of spinal surgery-related pathology. So our recommendation is a recording of clinical frailty score with comorbidities and also neurological status could provide more objective measures and also could also help us to get more information and also in the consenting process with the patient and also discussion with the family, which will be very important for them to know the possible outcome of the pathology. Thank you.
We do have time for some questions, if there are any questions. Can I ask a question? Then,
Oh, yeah.
has this changed your practice at all?
Well, this study we just concluded in January, so I think we're going to be doing the next stage. Will be possibly we're going to change in terms of the decision making, and also this has actually changed the way that patients are being assessed. And what we want to try and see if we can potentially do a bigger study, which we maybe across more units, to see how we can record this and be able to discuss with the patient and have a documentation that we can discuss more with the patient.
Thank you. We've got a question on the floor.
Hi, sorry. I might have missed it in your presentation. It's very good. Thank you very much. Very interesting to see that improvement in frailty with the surgery. So that's great. The big question, I think, with the elderly and frailty is whether it's safe to operate on them. Does your study help us understand whether frailty is associated with higher morbidity or mortality with operating? And does it help us pick which people we should be operating on or what surgery we should be offering them?
Yeah, thank you so much. This is a retrospective study. I think the next thing will be a prospective study, so we'll be able to get information about it. I think what we've seen so far, especially in the elderly, is that this study has shown that in selected patients that we could calculate the preoperative clinical frailty score, and also this will also be able to help us to inform them in terms of how the outcome will be as going forward. Because I think one thing is that the expectation of patients when they come into the hospital is so significant. So we need to let them be in the kind of a frame of reality. We're not magicians, so we can only do the best for the patient.
Thank you. Thank you very much for that.
So could we move on now to Ben Davis with his talk, please?
Morning, thanks very much. So shift from myelopathy to a different question here, surgery and discitis. So origins of this were a ENAS training course, which is run for the neurosurgical trainings around Europe. And they have these sessions where you get all these European trainings together, lots of people present cases, and we have this sort of vociferous debate around what to do. And the spinal meeting led to some very divergent views on discitis. And I don't know, put your hands up if you like. So you've got a patient with thoracic discitis, empyema here, no neurological deficit. Does that patient get surgery? Just put your hands up if you'd offer that patient surgery. One, two, so minimal, so neurological deficit, no. So no, that's a no neurological deficit. Let's move on to this. What about discitis alone? Any surgery offers here in the UK? No. I'll skip forward a little bit, because if you're in Germany, it seems like you operate aggressively up front. And the arguments they have and put forward in the meeting were it's life-saving, you get microbiological samples, you prevent secondary deformity in a much more simplistic manner, and you reduce length of hospital stay. And, across Europe, there were some views towards that, the Dutch in particular, Wilco Pearl, for example, who's an eminent spinal neurosurgeon, which seemed at complete odds to my experience, and it seems the experience of the room here in the UK. So we sort of set up a group to sort of think about whether who's right, who's wrong, whether there's a middle ground. We started with a big literature review, very intensive, and you can see it ended up pooling around 11,000 patients into a qualitative analysis, and I'll share specifically 8,500 patients in a meta-analysis. I think the first thing to say is this is the headline, so early surgery has a survival benefit. I think the first thing to say about the studies are not randomized, observational studies, very heterogeneous, so we've got to be careful about how we think about this. But there is a strong effect to early surgery on survival, as the Germans told us. That is shown again here, and also extends to length of stay. So there's an 8-day benefit to early surgery in terms of length of stay. So complicated data set, lots of potential confounding, and again, I think areas to get into debate about the validity and the generalization of those findings. But I think one of the interesting things that comes out when you try and control for these factors is the effect size increases for isolated discitis. So if you look at just the patients with empyema, their impact of surgery is actually lower than the actual discitis patients, so don't know. And then we do see that normal patient factors stack up in terms of response to surgery, so the drug users, the diabetics, etc., are factors in terms of that outcome. So very brief headlines of a paper that hopefully we publish shortly, but I think it leaves us with more questions than answers ultimately, and I think recognizing a very divergent practice is a question of whether we need to think differently again about this and perhaps offer a more detailed analysis of the data, but I will leave that more there with thoughts than necessarily answers.
Thank you, Ben.
Thank you. That's a very interesting study. Why do you think we don't do surgery in this country?
I might have to offer that one to the room. Has anyone in the room got a better answer to that? Yeah, go on. Yeah. Yeah. I think that's absolutely potential here, absolutely potential. The Germans are actively putting their data together. They don't have a selection bias. Everyone gets surgery, so we may see that. I mean, I think generally my limited experience of spine surgery now is when you have a complete dichotomy of views like that, then there is a bit of push and give from both sides. So it's possible that we're not doing enough. We didn't seem to say, and maybe the Germans are doing too much. But it's interesting to have such divergent views of practice in very, very similar systems. Yeah.
Any other questions? Thanks, Ben. Can we ask? We'll bring to the Chinedu Egu is going to be talking about how to treat Cortoquinas syndrome in pregnancy, a systematic review and critical appraisal of the current evidence.
Hi, morning. Thanks to the BritSpine for inviting us to discuss our paper. My name is Chinedu Egu. I'm one of the core trainees at Nottingham. We presented our paper on Cortoquinas syndrome in pregnancy, systematic review. These are my co-authors. We have no conflict of interest. So generally, we know that Cortoquinas syndrome is pretty rare. It's a spinal surgical emergency, like we've heard over the past couple of days, occurring in 1 to 300,000 people. In pregnancy, it's even rarer. So no wonder the rarity of literature. But what we try to do is we try to find out what's the trend of Cortoquina in pregnancy. What are the symptoms and signs? What is the decision-making process? How are the patients positioned? What are the modes of anesthesia, modes of delivery? What are the surgical outcomes? So these are things we're trying to find out. So we followed the PRISMA guidelines. We searched these databases. We included patients who had Cortoquina, related symptoms and signs, management and surgical outcomes, just seeing what's happening out there. And we pulled 510 papers from the literatures, but we only identified 26 studies which met our inclusion criteria, and all were level 4 evidence. We included 30 patients. Mean age at presentation was 31 years. Mean gestational age was 26 weeks. The mean postoperative follow-up period was about 35.4 weeks. Now, this was the distribution of symptoms. However, we couldn't find any of the symptoms that was specific for Cortoquina in pregnancy because low back pain, urinary symptoms, leg pain, these are symptoms that could also be found in normal pregnancy without any Cortoquina. So the question is, are there any symptoms that we can actually use in pinpointing that Cortoquina is happening in pregnancy? But these are very regular symptoms that you could actually find in pregnancy. The examination findings was quite interesting, where we found that pinprick and light touch loss at the saddle region were the commonest examination findings. So that points to, okay, and those are like very strong clinical signs for Cortoquina as well. We know that disc herniation is the commonest cause of Cortoquina generally. In pregnancy, it's the same, but we need to pay attention to those other hemangioblastoma, carcinoma, spinal canal stenosis, epidural venous engorgement. In fact, one of the patients actually, following delivery, her epidural venous engorgement was relieved and she didn't need any spinal surgery, so we need to pay attention to that as well. Now, decision-making, multidisciplinary team was utilized in about 73% of the public literature, including obstetrician, neonatologists, surgeons, and anesthetists. That's very interesting and very important. Anesthesia, 73% of these patients were anesthetized using general anesthesia. Just 27% had epidural given to them. 70% of these patients were position prone. If above 12 weeks, they tend to use the Relton Hall laminectomy table. And then 30% of these patients were either positioned on the right position or left lateral position. And 80% of the surgeons went ahead to decompress this patient despite the trimester. First, second, third, doesn't matter. They compressed within 48 hours. There were some delays with 20%, even up to 1 week delay. Most of these patients were delivered post-spine surgery. So they had spine surgery within pregnancy, carried the pregnancy up until term, and delivered this patient via their babies via cesarean section. The average time between spine surgery and delivery was about 9 weeks. We had some others that actually had cesarean section before spine surgery, and those who delivered via vaginal delivery after spine surgery. But none of these patients actually had vaginal delivery before spine surgery. We saw a trend. It wasn't statistically significant, but it's just a trend, saying that patients who came in the third trimester, patients who had minimal invasive surgery, patients who had surgery within 48 hours, and patients who actually had cesarean section after spine surgery tend to have better outcome compared to other cohorts. But they were absolutely not significant, actually. Now, we also found out that bladder and bowel symptoms seem to have better resolution at follow-up compared to other symptoms that are presented. However, we're not certain if this is due to relief of the pregnancy or due to decompression. And yes, it's a small number. We had poor methodology in the published literature. There was lack of randomization. However, we're able to, we've made the first attempt to actually discuss what are the trends in management of Cortoquina. We found out that multidisciplinary discussion is paramount. It's actually the key. Every patient must be individualized. And then we've seen trend of improved outcomes if you decompress within 48 hours, if you had minimal invasive surgery done, or third trimester surgeries, or cesarean section after you've had spine surgeries. But these are just trends. Thank you.
Any questions?
Hi, Kaushik Ghosh from Preston. Good paper, good thing to see. Can I ask you what you meant by minimally invasive surgery in Cortoquina?
Okay. So it included, so the papers might not elaborate on what they did, but what it said was endoscopic surgeries, or they stated categorically they're doing minimal invasive surgeries and not open surgery, like the non-invasive, non-minimal invasive. So either they stated endoscopic or minimal invasive, but they might not necessarily elaborate on what they did.
Okay, thanks.
Thank you very much.
Any other questions?
Hi, Hoylinka, Gloucester. Did any of the papers describe any complications with the fetus or gestation of the rest of the gestation in those papers? And were there any emergency C-sections performed as a consequence of their discectomy surgeries?
So the fetal outcome, we had about 80% of healthy fetus, but we had most of them were actually delivered healthy, but we had one child die at 5-day post-delivery because it was delivered in the second trimester, so died of some pulmonary complications. But that was after delivery. At the time of delivery, was healthy infant. So we had actually majority of them. The remaining 20%, no data was reported about it. So I could say with the reported data, it was 100% healthy fetus, but in the grand scheme, it's just 80%.
So it sounds like all the fetuses were carried to term.
Yeah.
Okay, thank you.
Thank you. And one last question at the back.
Yeah, Christopher Lee from Hull. A small proportion,
underwent normal vaginal delivery
Yeah.
after surgery. Two things. Were there any issues with that?
Okay.
And secondly, timing. So how long after surgery were those deliveries? And when would you consider it safe to recommend a normal vaginal delivery after surgery?
Yeah, so thank you very much. So so the papers that discussed that, they stated clearly that it was an MDT discussion, and at the MDT discussion, they finalized that it's safe. It's been weeks after spine surgery. So actually, it was actually weeks, not necessarily post-spinal surgery. Sorry, a couple of days. It's weeks. So they've said, she's had spinal surgery weeks ago. I suspect that we can actually have a safe delivery here. However, we're on standby. If there's need for any emergency conversion, we will do it. So let's push.
How many weeks?
I don't have the data about how many weeks between them. I'll have to look at the paper. Thank you very much.
Thank you very much.
Could we have Jose Miguel Souza, please, next with his paper?
Hello, good morning. My name is José Miguel Sousa. I'm from Lisbon, Portugal. I'm a spine surgeon, and I'm here to present the results of our imaging study on transforaminal endoscopic access to L5S1. So I have no disclosures. And as we all know, transforaminal endoscopic surgery has a wide range of accepted indications. However, at L5S1, there are some singularities, namely the iliac crest correlation, the foraminal and facet joint morphology, also the L5 dorsal root ganglion anatomy, and the slope of the disc space. So basically, we tried to determine the pelvic and lumbosacral reference parameters through CT imaging, and we controlled this data in low back pain patients in a control group. Also, we tried to determine the quantification data and morphological correlations for this type of access. We had, after the inclusion and exclusion criteria that were applied, 100 patients in the low back pain group and 100 patients in the control group. Basically, we defined and tried to measure the pelvic and lumbosacral anatomic parameters and the L5S1 approach parameters. Here, we tried to identify what would be the minimum and the maximum approach angle, what would be the working angle, and the projected minimum and maximum skin incisions. We also tried to identify several of the correlations of the L5S1 approach with the iliac crest. Here we can see how some of the measurements were made using some axial cuts. The maximum axis angle would be based on the central point of the disc space going through the SAP of S1, and the minimum axis point to the most anterior point of the disc space and going again through the SAP of S1. We used a grading system to see the iliac crest height, because it's important to determine that we know that usually when you go for the iliac crest height, you just see the maximum height at its projection. That may not correlate to the exact point where the approach will in fact be in conflict with the iliac crest. So in our results, there were more females in the low back pain group. It's in accordance to the literature. And by doing a subgroup analysis by sex, we saw that the iliac crest was in fact higher, and the potential intersection with the iliac crest is higher in males. So there was a higher chance of conflict. In the rest of the parameters, there were no differences between the low back pain group and the control group. But basically, we were able to determine values for several of these parameters for determine the axis, and so to help us in the preoperative planning. And we also got to this data. Basically, we saw that by at least doing the minimum iliac intersection, very, very few patients would have an actual conflict with iliac crest to do this approach. And we also saw that the iliac crest at its highest projection was significantly increased to the actual trajectory of the approach. Besides that, we did the correlation between all the parameters, and we'll detail them a little bit and see what the correlations were. And so basically, We were able to set reference values for access and working angles, the correlation with the iliac crest, and also for skin incision planning. The iliac crest intersection with the potential approach for L5S1 is related to higher iliac crest height, a higher angle of facet joints, and the distance of the intersection point to the spinous process. We also found that the iliac crest height is correlated with a higher pelvic incidence. So basically, the projection of the iliac crest at its highest point does not correspond to the point of conflict with L5S1 transfemoral approach. Very few cases will the iliac crest preclude an L5S1 transfemoral approach. The risk of conflict is higher in males, and basically there were overlapping morphometric and L5S1 approach parameters between low back pain group and the control group. So thank you very much.
Thank you very much. Are there any questions? Can I ask a question?
Yes.
How did you recruit your control group?
Basically, we had all patients that would go for a CT scan, either for urologic or that were referred for a thoracoabdominal CT scan, but had no lumbar conditions. They were all screened. All patients that in the previous 6 months had low back pain complaints, not chronic, but even a single complaint, or radiating to the legs, they were excluded.
I think, is the question there? No? Just standing up. Could I ask a question? Clinically, if you're planning surgery, would patients require a CT scan, or is this just for the study?
This was for the survey. Usually, we use MRIs for most of us. Actually, the results we have can be translated to MRI, but we had to do a 3D MRI. That's also not, at least in our department, it's not the most common, but it's possible to translate these results to 3D MRI imaging.
Thank you. Thank you.
Thank you.
Right, so can we call Jade Cuthbert up, please, to talk about Spondylosis. Can recent historical microbiology results help guide identification of the causative organism?
Hi, good morning. I'm Jade, and I'm one of the spinal nurse practitioners from the Norfolk and Norwich University Hospital. First of all, I just want to say thank you for letting me present this project, looking at whether using recent previous microbiology results can help guide antimicrobial choice in patients with spondylodiscitis, but where no causative organism is identified. We have no conflicts of interest to declare. Pyogenic spinal infections are rare but serious conditions with reported mortality of up to 20% in inadequately treated patients. Spondylodiscitis is the most common pyogenic spinal infection and has had increasing incidence rates over the last few decades, with incidences predicted to be around 30 per 250,000 in 2015. We know that most cases can be managed with medical management alone, and that early diagnosis and treatment lead to better prognosis. But in order to guide antimicrobial management best, a causative organism should be identified. This pickup rate of identified causative organisms in the literature is between 25 to 59% for blood cultures and 57 to 92% for biopsies. It is therefore reported that in around 50% of cases, no causative organism is identified. For relevance, our local guidance is that if clinically possible, all patients presenting to our unit with suspicion of or confirmed discitis have 3 blood cultures prior to starting antibiotics to try and identify the causative organisms. Then all these patients will be discussed through our MDT meetings with the spinal surgeons, MSK radiologists, and a specialist bone and joint infectious microbiology consultant. We aim to assess the number of patients treated locally without a causative organism. We know most infections are through haematologist spread, but cultures are often negative. So we aimed to assess whether previous positive results can help identify the causative organisms, and we specifically looked at urine cultures in the previous 6 months to admission. So we performed a retrospective notes review of all patients treated with Spondylosis between 2014 to 2021. We identified all adult patients with a new diagnosis of Spondylosis, with MRI supporting this diagnosis, and were treated through our tertiary centre. We excluded 2 post-op infections and any recurrent infections. We collected data on the primary admission for Spondylosis, including microbiology investigations, and subsequently reviewed any microbiological samples sent within 6 months. We identified 235 patients over that time period, with a consistent number of cases each year, as shown in the graph. The age for the patients ranged from 20 to 91, and the mean hospital stay was 37 days. So overall, when we investigated the causative organisms, we looked at blood cultures first. As you can see, 22 out of the 235 patients had no blood cultures taken. We had 94 patients that had 1 blood culture taken, of which 41 of the 94 were positive. 119 patients had 3 blood cultures taken, of which 65 were positive. So by taking the 3 blood cultures, we were able to increase our positive yield by approximately 10%. I then looked at biopsy results. For biopsies, we had 51 of the 235 patients biopsied, of which 6 of these were in patients who had no blood cultures taken. And out of the 32 positive results, there was 32, out of the 51 biopsies that were positive. These pick-up rates for blood cultures and biopsies cultures were consistent with the published literature, and overall a causative organism was identified in about 54% of cases. There was 37 different organisms that were identified for Spondylosis, and we had 19 cases that were polymicrobial. Staph aureus occurred for almost half of the cases, 2 were MRSA, and there was 1 case of TB discitis within the cohort. Okay, sorry, bear with me on this one. Patients were then stratified for analysis of prior cultures. So of the 235 patients with MRI-confirmed Spondylosis, 127 had a causative organism identified. Of these 127 patients, 82 had a previous urine culture sent. Of these patients with no causative organism identified, 66 had a previous urine culture. 22 patients had a positive urine culture and a causative organism identified. These 22 patients were then analysed further to see whether previous urine culture results may be able to help with identifying a causative organism in culture-negative patients. So, from the 22 cases that were analysed further, the organisms matched in 7 of the cases. They were either E. coli or Staph aureus. Although numbers were small, in every patient with a Staph aureus in a urine culture, a Staph aureus was identified as the organism in the Spondylosis. Okay. So, in conclusion, our large data set produced results consistent with published literature. We found that despite the low numbers, there was a 31.8% match in causative organisms in positive urine cultures. Staph aureus in the recent urine culture may be predictive of a Staph aureus Spondylosis. So our take-home message is that previous urine cultures may aid antimicrobial decision-making in those patients with no organism identified, but we feel further prospective analysis is required. Thank you very much.
Thank you. Are there any questions?
Hi, thank you very much for your presentation. I'm Andrea Nier from Sheffield, University of Sheffield. I wanted to ask you how exactly the culture conditions looked like, since you only have aerobic bacteria detected and no anaerobic ones.
Sorry, do you mind repeating that?
What exactly were the culture conditions for your microbial cultures?
I don't know. Tom, can you help in that? Yeah.
So all of our cultures are sort of routine NHS culture media, so they all get sent for both aerobic and anaerobic culture. It just happens that we didn't grow any anaerobes.
For how long?
So they all get cultured so they're all put in for 48 hours, and then extended cultures are performed if they're negative, which is up to 1 week.
Okay. Okay.
Thank you. Question at the back.
Oh, very good results. Very impressive CT biopsy results, I can see, compared to most of the units. Is it because you don't start antibiotics till you have done the biopsy, or you're taking a bigger sample? What is the trick for higher biopsy rate in CT?
I honestly, I'm not sure. Tom or Leno, can you help me?
Some of it might be technical. One of our MSK radiologists are of the view that if you're doing a biopsy, you must violate the end plate. So it's not sufficient to do a transpedicular biopsy. You've got to get across the disc. Some of it might be technical factors from our MSK radiologists. If patients are septic or unwell, we start them on antibiotics, you have to. And quite often, the culture absent people, the people who've had no blood culture, have been under the physicians. And you'd have thought, the physicians would have thought to blood culture them. But we find that a lot of patients are started on broad-spectrum IV antibiotics in the absence of any blood culture. So I think that yield is a bit higher than we anticipated. But I think it may be technical factors, and we tend to not give them antibiotics if we can avoid it until we biopsy them.
Thank you.
Thank you. I think we have time for one more question if there is.
Thanks. The obvious implication of saying that the same Staph aureus was in the urine as in the infection is that it was the same organism. We know that patients with UTIs are at greater risk of getting post-operative joint infections, having total joint surgery, but when we look at the actual serotype of the organism, it's usually a different one, and it suggests that it's simply that they have a predisposition to infection. Do you know whether your organisms from the urine and your organisms from the disc were actually the same Staph aureus or different Staph aureus?
That I don't know, and that's something that I'll probably look into taking further.
We definitely don't know that, Mark. And what was disappointing is what we'd hoped was to revolutionize spine surgery and find that in 100% of patients, the organism correlated with the microbiology in the urine for the previous 6 months. That had been amazing, but we didn't come close to that. And it was a disappointing negative result, but I think it's an important, it was something theorized by our microbiologists for a long time. You know, these people are predisposed to infection. If you look back at their microbiology for the last 6 months, is it likely that they had a source of sepsis in the prior 6 months? And we were a bit disappointed to find that that didn't seem to be the case.
Thank you both.
Thank you. Could we ask Jennifer Carroll to come up?
Good morning. Just want to start by saying how fantastic it is that I'm able to be here to share this fantastic work that we're doing with you all. We're looking at how we can implement continuous improvement methodology to review our Cortoquinas pathway. I'd like to pay thanks to the wider team at Lancashire Teaching Hospitals. I'd like to pay thanks to the big room attendees across our integrated care system. And I'd like to most importantly thank our patients for their support and contribution to this programme of work. Together, we are demonstrating that we can unite as a system, we can cross organisational boundaries, and we can start to make positive changes together moving forwards. I have no declarations of interest or conflict. For our Cortoquinas pathway syndrome, if we have a robust and effective pathway, we're going to help to support the negation of potential catastrophic outcomes for patients and for clinicians, and also to support with the capacity and demand pressures that we all currently face across our systems. Our patients are central to this improvement work, and their voice is informing our strategy, and that's the most important thing for us, that our patients are really involved in this work. The passion and enthusiasm for this work is palpable, and that's demonstrated in the diverse engagement that we've been able to obtain within our big room. And together we're looking at this complex pathway, splitting it down into sections and agreeing as that wider group what our priority of focus is going to be moving forwards. So we are utilising Flow Coaching Academy methodology, something that I don't believe has been discussed over the past couple of days, unless it's been a conversation with myself where I've managed to have a conversation with you about it. So Flow Coaching Academy methodology is an improvement methodology. We have built a system-wide big room. A big room is a space for key stakeholders to come together, to meet, to have positive challenges, to explore opportunities for improvement through the identification of change ideas. We have a flattened hierarchy within our big room. We utilise effective meeting skills, and we try to maintain a focus upon action. We look at the change ideas and we develop them into small tests of change through PDSA cycles. And because this big room is system-wide, those small tests of change are going to help us to build confidence with change, because we can test at a small scale but share that learning larger across our system together. I've already mentioned that we've got really diverse engagement within our big room, as demonstrated just with some of the examples of who is part of that big room. You can see that our patients are at the centre of that. At the moment, the patients are part of our big room through their stories that they've shared with us through patient interviews. We meet weekly on a virtual platform, because this is system-wide geographically. That makes this a sustainable way to meet and progress this improvement work forwards. But our patients have attended to face-to-face events that we've also organised to personally share their journeys with key stakeholders and really remind us why we are doing this improvement work together. A real key thing for us is that we've also got legal representatives within our room so that we can actively learn from litigation. We have developed aim statements together, and our global aim statement is shared here with you all. And for us, we are looking at standardisation of process. We've mapped out the process from initial presentation with symptoms to diagnosis and development of treatment plan. And you can see some of the key emergent themes on the side, which have come out of the patient interviews and patient stories, but been combined with the lived experiences that our clinicians have shared with us. Some of that's already been mentioned even this morning. The variation, the duplication, communication barriers, the time delays, how we can most effectively utilise our resources that we have available now, but also considering how we could utilise resource differently moving forwards into the future, all of which supporting that timely clinical decision making, improving patient experience, improving patient outcomes, but also supporting each other as colleagues and as partners. We've developed a robust measurement strategy, as demonstrated here, considering various different measures. It's going to be important for us that we analyse data over time and look for statistically significant impact upon that data. We really need to understand the impact of the small tests of change that we're implementing. We've started looking at our tests of change within ED department, and indeed this week, from Monday until the end of tomorrow, we've got 3 of our acute hospital sites testing out having Cortoquinas champions, so clinicians identified as a champion who can utilise a standardised digital assessment tool. Again, assessment has come up this morning, so looking at how we can really test out that assessment and that Cortoquinas champion role. We're really trying to understand our data and make our data come to life and make it physically usable. This is one example. This is a baseline Gantt chart where we looked at patients coming through into the Preston ED department over the course of 1 month. We'd identified the key steps within that pathway, and we'd mapped those out for each of the patients, looking at the time between steps so that we could have some really meaningful conversations about what are appropriate time gaps between steps, but also where there's scope for those change ideas to be developed and tests to be developed, and also for these to be taken out back to clinical teams in diagnostics, in therapies, in surgical teams to look at what could we do next and what could we explore. We are unique as a big room. We are system-wide. We have legal representatives so that we can actively learn from litigation. And we've also made links with our local, regional and national GIRF teams, and I'm aware that Mike is here and GIRF are here with us. We really want to demonstrate how we can utilise best practice guidance to springboard improvement work forwards. Our big room is very creative, and we really support those creative ideas flowing, but we also want to utilise best practice guidance to inform some of those tests of change so that we can move forwards together. And indeed, Mike attended our face-to-face event, and we've discussed with Mike how we can feed back our data. So the new guidance has just been released, so how can we test that out as an improvement group? How can we feed back the data that we are obtaining to our GIRF team so that we can, again, really work in collaboration to support our patients and to support one another and look at how we improve our Cortoquinas pathways moving forwards. So I'd really like to thank you for taking the time to listen to me, whether it was in this 5 minutes or whether it's been over the past couple of days. I've had some really meaningful conversations with some of you about this improvement work and about what we're doing. I've explained that this is system-wide for us at Lancashire Teaching Hospitals, but I think this is something that we could maybe springboard even further and think about how we share the improvement work and the research that we're all doing so that we're utilising our time most effectively. Time is precious. And if we can really effectively share what we're all doing, we're going to be able to move forwards far quicker and at pace. Thank you.
Thank you.
Are there any questions? I'd like to ask a question, if that's okay. I mean, it's fantastic work that you're doing, and I think it's amazing that you can try and bring the whole system together. But how long will you plan to meet and evaluate the pathway every week? Because obviously for most pathways and services, it's not feasible to delegate that amount of time to analysing a pathway. So for how long will this, you know, at what point do you say, right, it's up and running well enough, and how do you know that at that point?
So we've been linking in with business intelligence and our data analyst teams as well, and we've been asking them, I'm sure a lot of you can appreciate that often manual data collection is part of this, and indeed our teams this week will be manually collecting data on the impact of the test of change. But we've been talking to them about how can we have some live data feeds so that we're actively, because there will come a point, you're right, where we're not going to be able to continue to meet weekly, but some of those tests may still be happening. So how can we get that live data feed? And on that Gantt chart that I was showing you, we were looking at, well, what is time-stamped, what is electronic, what is available to us that we haven't got to do that manual data collection? And we've obviously been looking at Lancashire Teaching Hospitals, but again, how can we do that bigger? How can we have those large data sets that we can access, and that will help with that sharing of information? Cortoquinas syndrome pathway is very complex, and we were very aware. A big room, by the way, is normally just at a trust level. It isn't normally at system-wide, but we were very aware that whatever tests of change were all happening, and we were very aware that lots of people want to improve this pathway, that we had to go bigger than that. So there's a definite place for thinking about data, how we're collecting it. We want to collect it for a long period of time. We're starting to see already that we are seeing a reduction in out of our radiographer call-outs, which is really significant, and that was placing significant pressure upon our workforce, and not just the impact on patients, because obviously that's the first thing to consider. But I think the key with this is going to be the data. How can we get those live data feeds? How can we make that appropriately accessible, and how can we understand what we're all testing so that we know what has influenced that data and what's going to be sustainable? We've talked a lot about in our big room about what can we change now, so what's within our resource to change. And especially with our legal representatives, we've been talking about the documentation of assessments, we've been talking about the standardisation of assessment, we've been talking about handover processes, safety netting cards. So there are things that are within our gift now to change, so we really need to get that data feed coming through quickly. But ultimately there may be things moving forwards when we've explored everything within our resource that we need to have that data and that evidence behind, yes, not only as a surgical department, as a system, we have explored absolutely everything within our resource, and this is our evidence and our data to support that. These are the changes and the positive impacts that we've made. But in order to progress further and to help with some of those, reviews of how we use future resource and investment, the data is going to be key to this moving forwards.
Thank you. And can we call our final speaker to the top? So it's Claire Spalton-Dean, who'll be talking about when should we use intraoperative cell salvage in spinal surgery.
Good morning, ladies and gentlemen. My name is Claire Spalton-Dean. I'm one of the orthopaedic trainees down in Exeter. Thank you very much for the opportunity to present our small project. We have no conflicts of interest to declare today. So, within spinal surgery, it is well accepted that blood loss is a significant risk, with undoubtedly all of us consenting our patient for catastrophic hemorrhage. It makes sense that the more complex the surgery, the more levels involved, the more blood loss is likely to occur. And therefore, we will take steps to mitigate this, and cell salvage is one option. There is no good evidence in the current literature on when cell salvage should be routinely utilised. The BAS vascular injury policy suggests that cell salvage should be used if available, but it's certainly not mandatory. For those of you not aware, cell salvage is a system by which fluid is collected, processed, and reinfused into our patients as an auto-transfusion. Within our unit, it is set up on a case-by-case service, and that can lead to discrepancies and also confusion within the team, rather than being a protocol-driven service. We collected data from our blood transfusion department and performed a retrospective review of all spinal cases that had interoperative cell salvage set up performed between January 2020 and September 22, and assessed for various different areas. It's worth bearing in mind that this is during part of the pandemic, and so spinal services were not running normally during that time period. We identified 382 procedures and looked at demographics. It's worth noting that 94% were planned procedures, with only 6% being coded as CPOD 1 or 2. We were interested to note that spinal surgery was the second biggest user of cell salvage within our hospital, with vascular surgeons only coming in fifth, and our obstetric colleagues using the most. The vast majority of cases, 69%, collected sufficient volume to process and give our patients an auto-transfusion. 8% of the cases that we looked at resulted in a subsequent red blood cell transfusion, and all of those cases had collected sufficient intraoperative cell salvage volume for these patients to also have a transfusion from that. We broke down our case mix to see if we could identify any particular trends, rhyme or reason that we could deliver some hopefully hard-hitting messages. Unfortunately, there were quite a small lot of patients and a large heterogeneity in our cases, which meant that actually in groups there were quite small numbers, making it hard to glean significant data. But I'll take you through what we found that we thought was interesting. As would be expected, adult deformity cases had a large volume of blood loss, with all of our patients receiving sufficient volume for cell salvage, with an average of over half a litre being reinfused. Approximately a third of adult deformity patients also required an allogenic red blood cell transfusion, and this has changed the way that we consent our patients. All of the patients that received a subsequent transfusion had 8 levels or more operated upon. As is consistent with the current literature, scoliosis surgeries also had a large volume of blood loss, and 97% of cases collected sufficient for cell salvage to be utilised. We did note that on average, these young patients were having an average reinfusion volume of almost half a litre, which would be equivalent to a 2-unit red blood cell transfusion. Looking at cervical cases, we were not surprised to see that our posterior 360 fusions and our corpectomies had large volumes of blood collected. However, what we were interested to see was that in over 20% of our ACDS, they had sufficient blood loss for cell salvage to be utilised. Looking at that further, these cases were all 2 levels or more, and so we have changed our practice so that those cases only would have cell salvage set up. Looking at lumbar decompression, approximately 60% had cell salvage. And I was hoping when I looked at the data, I'd be able to say, oh, there's a critical point level. But interestingly, there was no significant difference between the 1 to 2 level decompressions and the 3 or more decompressions, with them usually losing about 200 mils and being given about 200 mils. ALIFs, we were surprised, they had one of our lowest rates of intraoperative cell salvage being given back, and none of them had a post-transfusion. We did think it was worthwhile noting that actually interoperative cell salvage processing to set up and give patients an auto-transfusion is quite a cheap option, particularly when we compare it to the cost of a red blood cell transfusion for our patients. And unfortunately, in this time of austerity, and especially given the recent difficulties with procuring blood, it is something that we as clinicians probably do need to take into account when we're planning our procedures. So we do acknowledge that we have quite small results, quite small case study, and therefore it's likely underpowered, and particularly given the heterogeneity of the cases. We also acknowledge that the COVID period reduced the operating numbers. So unfortunately, none of the results we've presented have any significant statistically, but we do think they are certainly interesting. So we think that, unfortunately, we haven't answered the questions on when it should be used. We think that probably it is underutilised within departments, and we would suggest a national collaborative study to look at this further in order to make formal recommendations, which would allow for appropriate theatre resource planning and also discussions regarding the use and the likelihood of blood transfusion with our patient cohorts. Thank you very much for your attention. I would be delighted to answer any questions, or if you want to have a coffee, that's all.
Thank you. We've got a question from Mr. Golash.
Well, thanks for highlighting the benefits. Have you compared your blood? I'm really surprised. 69% of spinal surgery requiring blood transfusion. I think most surgeons perhaps will need to look at their practice. Have you compared the blood loss against published literature?
So that was 69% of patients had sufficient volume collected in intraoperative cell salvage to receive an auto-transfusion. So there is very little data looking at specifically cell salvage. So we're not saying that these patients would have been sort of in the post-operative period in a post-op HB drop. We haven't looked at that, and if they would have received a transfusion afterwards if they weren't symptomatic. But if they've lost it, we can collect it, give it back, and it maybe impacts their rehabilitation. That seems like a good thing. We do everything possible to mitigate and minimise blood loss. So if we can collect and return, then that seems like a worthwhile
Really? Anyhow, thank you.
Can I just clarify a quick point? That 69%, was that 69% of the times you used Cell Saver,
so that was just,
or the whole cohort?
So that was it was just looking at patients where intraoperative cell salvage was used.
So when you used it, it was useful in 69% of the case. Yeah.
Yes.
So I think, should we go to the front?
Thanks, Claire. Did you find any data or subset analysis on patients with MSCC and cell salvage?
So we looked, and we only had 6% of our patients who had metastatic cell salvage, metastatic cancer in the cohort that we looked at, and that was a very, very small number. So we weren't able to look at anything sort of.
Because it looks like they were the ones who had the corpectomies, but did you have any data on those who might have had decompression surgery as well as fixation?
Yeah. So there was no statistical difference that we were able to identify, but I think it's likely because they were underpowered.
Thank you.
Thank you. One last question.
Kaushik Ghosh from Preston. It's interesting because you are still saying it's underutilized. I've noted it was 22% cases of ACDF, it was enough bleeding. So how did you decide which ACDF cases you will use Cell Saver?
Yes, I think that's another limitation of this study. So we only looked at patients in which cell salvage was already set up. So that was the data that we were able to collect from our blood transfusion department. So one of the limitations is it was a case-by-case discussion with the senior clinicians who actually had cell salvage set up. And we wanted to look, and unfortunately we looked at BMI, preoperative clotting and things, and there just wasn't enough data to sort of to work out why these people had decided, and whether it was just on the day, oh, yes, we probably should set it up. But we were trying to look and see if there was any reason as to how we chose those patients, but we just don't have enough information. And I think that's something that potentially a national collaborative study would gain, and kind of getting everyone's sort of anecdotal and sort of experiential input onto how you select which cases we use it for.
Because based on whatever literature, ACDF very, very, very rarely needs a blood transfusion.
Yeah, absolutely, which is why we were surprised that one, it was set up in those cases, and two, that actually over 20%, but they were 3-level cases that required, that had sufficient to be receiving an auto transfusion.
Thank you.
Thank you.
Thank you very much.
Thank you.